Good afternoon, Ajahn and everyone. My name is Jinjudhapak Thongdee. Today, I would like to present my research in the topic of the relative occlusal force of single posterior implant supported big processes, a prospective pilot study, which supervised by Dr. Warirat Prabhakar and Associate Professor Praved Seri Chetapong. Today, I will cover all this topic. Let's start from the introduction. So the whole idea of this study came from the fact that implants differ from natural teeth in many aspects as shown in this picture. The most important thing is that the apical ligament that function as shock absorber and stretch distributor are absent. With all these reasons, dental implant has less force sensitivity compared with natural teeth, leading it prone to overloading. Overloading has been considered as one of the causes of marginal bone loss and mechanical complications, such as loosening of fracture or even implant itself fracture. So in 1994, Mitch and Bides has proposed the concept called implant-protected occlusion or IPO. This concept aimed to reduce occlusal force on implant processes to protect implants. The implant should have contact at heavy bite while no contact at light bite. With this approach, it helps to increase the longevity of implant and decrease risk of overloading. However, it was reported by several studies that implant-protected occlusion can cause problems such as trauma or root fracture to adjacent teeth, as J. Hong Lee and the group found in 2016, as well as Rosen's study in 2017. It showed that there was a possible association between implant and vertical root fracture in neighboring RCT teeth. So what is the cause of this problem? Back then, implant occlusion concept is only a clinical empirical. This is probably because the method that we generally use to perform occlusal analysis is using articulating papers. This method lacks reliability to illustrate occlusal loading, can check only one pair at a time, and cannot provide after occlusion data. With those reasons, in 1987, TechScan company was introduced the occlusal analysis device using computer software, which is called T-Scan. T-Scan is claimed that it can provide more accurate and reliable occlusal analysis, and also can check the occlusion of all teeth in one bite, as several studies reported. Occlusal force distribution and the relationship between time and force can be obtained. And the result will show on the screen in 2- and 3-dimensional images in real time. However, the clinical evidence of implant occlusion is still scarcely reported. Few T-scan studies previously reported about implant occlusion alteration after function. And surprisingly, none of them mention about implant occlusion and marginal bone loss. So the objective of this study were first to analyze the relative occlusal force of single posterior implant supported fixed processes among implant protected occlusion and load occlusal contact design by using T-scan system. And second, to compare the marginal bone loss between those designs over time. And this is the overall of the study. 12 patients who were required for a single posterior implant at the Aesthetic and Implant Clinic of Chulalongkorn University were randomly divided into 2 groups, which were implant-protected occlusion or IPO and load group. For the load group, implant processes delivered were checked to have contact at heavy bite and light contact at light bite, while the implant in IPO group were contact only at heavy bite. The relative occlusal force were measured by using C-scan system at 5 different times, which were before prosthesis delivery, after prosthesis delivery, after function 1 to 2 months, 3 to 4 months, and 6 to 7 months. For marginal bone loss, the preapical parallel X-ray will be performed by using individual jig at 3 different times, which were before prosthesis delivery, after prosthesis delivery, and after function 6 to 7 months. So for patient recruitment, the inclusion and exclusion criteria are as shown. Patients who age more than 20 years old and require only 1 implant were enrolled in the study. All implant sites were Hugh site and occluded with natural teeth. Patients with good parental, physical, and mental health, non-smoking, and available for follow-up were also enrolled in this study. While patients would be excluded when they're less than 20 years old, not at hillside, having unstable disease, TMD condition, smoking, or lost follow-up. And moreover, if patient receive any dental treatment that will alter occlusion during research time, such as fillings, extraction, or alternative treatment, patient will be excluded. There were two analyses in this study, which were occlusal analysis and bone loss analysis. So talking about the first one, the relative occlusal force were collected by using T-scan 3 from TechScan company at 5 different times, as mentioned earlier. At the time of implant cloud delivery, implant restoration was checked to have the occlusion accordingly to that group using RT4 and T-scan. Each patient was asked to sit in upright position before performing T-scan analysis. All patients were instructed to bite at the same position on the sensor. Then they were asked to bite 3 times at MIP position. The result is shown in 2- and 3-dimensional images with different color and bars as shown in this slide. The color will range from red, which is represent the higher force, to blue, which means the light force. For marginal bone loss analysis, periapical parallel X-ray were also collected using customized XCP. The customized XCP was made by adding acrylic on biplane. All the X-rays were performed digitally using PAC system. Before measuring bone loss, each X-ray was checked and calibrated by measuring the diameter and the length of implant in the X-ray, compared with the actual dimension of those implants as shown in this picture. Then the bone loss was measured from the implant platform to the bone at mesial and distal aspect. If the bone level were coronal to platform, the number would be in positive value. Then the difference in marginal bone loss between those times were calculated. For statistical analysis, there were 3 types of analysis would be performed in this study, which were first, cross-group to compare between IPO and load. And the second one would be case control to compare between control tooth and implant. And the last one will be within group, which is compared between implant at different times. All the data were analyzed by using SPSS. Shapiro wheel tests were performed first to check normality tests of the data. Most of our data were normally distributed, so independent t-tests were used for cross-group analysis. Pair t-tests would be used to analyze case control, and the repeated measure ANOVA were used to analyze within group. The result would be statistically significant if p-value was less than 0.05. Moving on to the result, 12 participants were randomly divided into 2 groups. Each group contained 2 men, 4 women, and the mean age of patient is 35 years old. 10 out of 12 identolast area are the first molar. And this study included implants from 4 different systems. So for the result, when comparing these 2 groups, the relative occlusal force between implant-protected occlusion and load group were not significantly different at any time. In addition, the force of both groups were increased during follow-up periods. When comparing between implant and contralateral tooth, the relative occlusal force between implant and control tooth of the IPO group start not to show significant differences after 3 months in function, while significant differences were not found in load group after 1 month in function. When focused on occlusal force of implant in each group, overall, the relative occlusal force of implant in both groups increased over time, and the rapid change of the relative occlusal force were found after 1 month in function. For marginal bone loss, after 6 months in function, the marginal bone loss between groups was not significantly differences as shown. And let's discuss the result. As you can see from this graph, overall the occlusal force of both groups increased over time, The interesting point is that the rapid change were found after 1 month in function. This change may be because the patient tried to use the implant and that side for function. So patient adaptation may play an important role here. However, the continued eruption can cause this situation too. From this result, recall patient is recommended especially after 1 month insertion. As reported by Rosen et al. Study, using implant-protected occlusion, the force tend to be loaded on adjacent teeth. This might be because the result that we use the articulating papers for implant by checking it not to hold healthy in light bite, which seems under occlusion and slower than it should be. Moreover, several papers show that even though the implant occlusion were carefully adjusted at trial delivery visit, the occlusal loading of implant after function could be significantly changed and diminished over time due to the continued eruption of opposing teeth. So this gap time would create more chance for adjacent teeth to receive higher loading, leading to pathology as mentioned earlier. While with the load design at this study, it will let implant contact slightly at light bite. This design still follow the implant protected occlusion concept that help protect implant, but will let implant contact faster with the help of using T-scans. Since one of the implant success criteria is lack of radiolucency around the implant and the bone loss of no more than 2 millimeters annually, and the study from Miyata et al. Found that overloading is associated with crestal bone loss. So marginal bone loss might be a good indicator whether this design implant occlusion is good. If the load design reveal more marginal bone loss than the conventional IPO design, it would mean that load design might not be the optimum implant occlusion we seek. However, since the results show that there is no significant differences in marginal bone loss between IPO and load group, the load design occlusion might potentially be the optimum implant occlusion. However, this study contains several limitations. First of all, this study was done during the COVID-19 pandemic, so finding participants and follow-up were challenging. Moreover, since it was a pilot study, the sample size was relatively small and the follow-up period is quite short. But for now, from this study, we can conclude that the relative occlusal force of implant increased during the follow-up period, especially after 1 month in function. So it was recommended that to recall patient, especially 1 month after insertion. In addition, designing implant occlusion as load design seem to have potential to be an optimum occlusion for implant. This implant occlusion design might help adjacent teeth to child loading better. However, further study with larger sample size and longer observation time is needed for clearer conclusion. Thank you so much, and thank you so much for having me.
Thank you, Dr. Jinjudhapak. Thank you for your informative presentation. Very good, very good. Okay. Is there any question from the audience? So I agree with you that the load design is the optimum occlusion design. So for the IPO, that means that is only light force, right? When patient bite, that is only light force.
The IPO, which means the implant protected occlusion design, which is the implant will contact only in heavy bite, while no contact at light bite.
Okay. So from your study, you say that the relative occlusal force that's increasing over time, right? In both group, in IPO group and the load group, yes. And what should we do if we found that in recall period, the relative occlusal force that's increasing? What will you do for the patient?
besides from this study, actually, when we recall patient, we should examination the patient and also the radiographic examination should be obtained. If you found that the relative occlusal force were higher over time, but if you take an X-ray and X-ray look fine, you can observe it more. But if you can see any like bone loss, you might have to adjust the occlusion.
Okay. So you mean that if we have the sign of the bone loss, but the bone loss that should come from the overload, not from the peri-implantitis, right? We have to dip that.
Actually, there's a lot of factors that can affect implant marginal bone loss, and one of the factor is overloading. And if we see any sign of bone loss, we might try to look for the reason behind that and try to get rid of that reason as much as possible.
Okay. So in this study, you have different type of implant system. Is there any different? Is there any different of the relative occlusal force or the marginal bone loss for different implant system?
There is no any differences were found from different system that the implant that I use. I know that there might be some limitation that is not studied just only the one system, but all the system in all the implant system that we use quite the same design, and also the platform is also the platform switching. So the different type of the system might not have much more effect in my study. And if we looking for the implant occlusion, most of the time that we adjust the occlusion, we adjust occlusion in the same, even though that we have a different types of brand.
Okay. Thank you very much for your answer and your very great presentation. I appreciate this very much.